Good evening, ladies and gentlemen. Welcome to the Harnessing the Power of Data Lumos webinar. Our speaker tonight is Adrian Power. Adrian is the collaboration lead for Lumos with the New South Wales Ministry of Health. Adrian is driven by working with people to improve health and business outcomes using data. Adrian has worked with various health organizations to leverage data, including government health departments, primary health networks, general practices, mental health and disability service providers. Adrian has qualifications in health science and data science. Please welcome Adrian.
Tonight's session is about Lumos, and I believe there are people in the audience who are new to Lumos and some people who are already participating in the program. So the session tonight will be a little bit of an introduction and overview of what Lumos is for new people, and we'll be talking primarily about the reports that we produce for participating general practices and some of the key insights and benefits that you might receive as a practice for participating. So throughout the session, please ask questions via the chat box, and I'll do my best to work through those as the presentation progresses, but there'll be plenty of time at the end for questions and discussion. So looking forward to hearing your thoughts through the session. And what you can hope to get out of it is really to understand the benefits of data linkage, interpreting the practice reports that we produce, and how you might be able to use those in your general practice. So without further ado, we'll get started. So what is Lumos? It's a program that links data between general practices and New South Wales Health. So our administrative data sets from hospital, emergency department and ambulance to de-identified patient records from your general practice. And it's the largest collaboration that we've ever undertaken as the Ministry of Health with primary care in New South Wales, so primary health networks and general practices. And it makes a data set available to health system partners for the purposes of health service planning. And really, it's an unprecedented opportunity to inform and underpin the transformation of patient care in New South Wales. And I'll give you a couple of examples about that later on. So Lumos wouldn't be possible without the participation of general practices. It's certainly voluntary. And as you can see on this chart, over time, the rate at which general practices have signed on to Lumos, so to speak, has been pretty constant. And almost 20% of practices now across New South Wales are participating. So thanks to those practices that are already participating tonight and those that are considering, hopefully this session will be helpful to you to understand why you might want to do that. So really one of the key benefits of participating is twice a year, you'll receive a report that's tailored to your general practice that gives you information about the services that your patients access across the New South Wales health system outside of your practice. So things like hospitalizations, ED presentations, ambulance, outpatient services are included in the report. And so it's a view of your patients that you wouldn't have access to otherwise. And so it's very, very exciting, and it's really the first of its kind. There's nothing like this in any other state in Australia. So we're lucky to have this. And you might be thinking, well, 20% of practices isn't that much. And we hope it's going to continue to grow as it has so far. With Lumos, the purpose of the program is really to have a health system view of what happens between primary care and acute care and the patient journey, and how we can use that information to help improve the system. So it's not designed to be a real-time, used for patient care in the real-time clinical setting. So what Lumos won't give you is information that John Smith was discharged from hospital last week. But what it will give you is, this is the proportion of your patients within a certain age cohort that were hospitalized over the last 12 months. So it gives you a bigger picture view of things. And for a bigger picture view, having just 5% of general practices meant that Lumos was representative of the population across the state. And so we can use it to guide health service planning. And as you saw in the slide just before, we're up to almost 20%. So it's now a really robust and helpful data set. And you can read that paper. There's a link on the screen if you're interested. So because we are linking data from your general practice with New South Wales health data, it's done in a way that's completely de-identified. And a lot of work has been put in around the governance and the security and the privacy to make sure that we have the trust of everyone, and it's done under ethical approval. I won't spend too much time on this, but there's a lot of information now on our website. If you Google New South Wales Health and Lumos, that gives you more information about our governance and so on, if you're interested in that. But all to say, it's a very privacy-focused program. So what is the information that's included? Well, it'll be the de-identified records of your patients that have visited your practice from 2010 onwards, or for however long you've been operating, if it was after that date. And those records are matched with those de-identified patients if they've visited a hospital in New South Wales, emergency department, if they've died, if they've been in an ambulance, if they've had an outpatient service at the local health district, they will be included, along if they've had a cancer diagnosis or a mental health ambulatory service. So quite a lot of information about services that a patient might have had or experienced through the health system. Some of the information that's included in those data sets, really the key information is around when the person accessed the service. So the dates of encounter or the dates of admission, some contextual information around that. So if it was an emergency department presentation, what was the triage category? What was the mode of arrival? What was the diagnosis? Same thing with an admission. What was the primary diagnosis for the admission? What were the secondary or additional diagnoses? And from the GP, what are the chronic disease flags that patient has? Information around pathology results and billing. So again, about service provision, but also diagnostic information. So what can we do with this information, and how is it helpful? And for what do we have ethical approval? It's for the purposes of the management, planning, evaluation, and funding of health services. So that can include compiling needs assessments, commissioning activities, and a good example is what we're about to go into the focus of, which is the practice report that we produce. So really understanding health service utilization. A bigger picture example of that is available also on our website. It's not really displaying nicely, but there's a link on the screen in the bottom left-hand corner. If you go to that page, you'll be able to download a PDF of what I'm about to talk to, as well as a really nice presentation that describes the methodology and how we came to these findings. And if you're interested, I highly recommend you do that, because it's a very interesting read and it doesn't take very long. But some of the things that we can understand from this linked data asset that makes it so special is what happens with the patient journey between primary and acute care. So this particular insight came from exploring one of the insights from a participating general practice very early on in the program. And that practice, through their practice report that we'll be talking about in a minute, saw that they saw that their patients visited them more often than the practices or their peers in the area, but they also seemed to go to hospital less. And so they wondered if there was anything to that. So we looked at that quite deeply to see if there was anything there across the state. And what we found is that if you're a patient that visits a high servicing practice, And the way we've defined that is any practice where on average, where 30% of patients, greater than or equal to 30% of patients visit at least 12 times over a 2-year period. So the average amount of times a person visits a GP in a year is 6.1. So basically above average, which is about 22% of practices. So if you're a patient that visits one of those practices, whether you visit that often or not, you're 10% less likely to have an ED presentation and you're 12% less likely to have an unplanned hospital admission. And you're probably older, from a more disadvantaged area, and more likely to have a chronic condition. So it's a really interesting insight, and we're keen to explore the contributing factors more deeply, because there's probably a lot that contributes to that, but it's a very interesting insight that I guess demonstrates the impact that primary care has to patients and the system more broadly. So I won't go on more about this because you can read about it in full detail on the website if you're interested. So to the main topic of tonight's presentation, which is really to dive into the practice reports. So for the people who are already participating in Lumos, this will help you get a sense of what you might do with the information and how you might interpret it. And for those practices that are thinking about participating, it'll give you a sense of why you might want to participate, because this is really what you get in return for sharing your data. So this report has been iteratively improved over the last few years. Lumos started from a pilot project back in 2016. So quite a long time now that we've been producing these reports. And over the years, we've taken on a lot of feedback from GPs about what's useful and informative to you. And we've applied that in this report. So hopefully it's as relevant as we can make it. Every report, starting a few reports ago, we introduced a condition in focus that changes every time. With the last report, or the most recent reports that have gone out, we've introduced the COPD condition in focus. So we'll talk a little bit about that as well. I'm just going to pause because I haven't seen the chat box and I just wonder if there's any questions at this point before we go on. Doesn't look like it. Okay, so when we're talking about these practice reports and when you see them, there'll be examples on the screen, so don't worry if you don't have one, you'll be able to follow along. We've got some terminology that we use throughout the whole report that'll make it easier to interpret once you understand it. Because the report is tailored to your practice, the patients of your practice will be represented in yellow. The patients of the PHN area will be represented in green, and the state will be represented in blue. And those comparisons can be really helpful to understanding the context of some of the information that's in there. So usually those three levels of aggregation are provided alongside each other. So the way you would interpret this chart, the yellow bar is your practice. And so in one of the socioeconomic sort of demographic measures that are in the report, it says for this example that 25% roughly of patients from this practice come from the most disadvantaged quintile, and 17% come from the least disadvantaged. And then you can compare that to your patient cohort to the green bar, which is the PHN, so the practices around you geographically, and also the state. And this demographic information can be really helpful in interpreting your report. We'll come back to that in a little bit. So the reports that have just gone out for those practices that are already participating are for the April 2021 data extraction. And that report covers the calendar year of 2020 from January to December. So it's 1 year of activity. Why is it 1 year? Because what we've heard from GPs is that the most recent year is the most relevant and the most useful. So that's what we produce. And the information is a little bit delayed because our hospital data takes a little bit of time to process. And so by the time it's linked, you get the report approximately 6 months after the linkage has occurred. So it is a little bit delayed, but for this kind of reporting, that's actually pretty snappy in terms of how quickly it's turned around. And we're always looking for ways to speed that up. So just to set your expectations there. So tonight we'll be looking at 2020. Going back to that demographic interpretation, we understand that every general practice is different. You might be a practice that visits residential aged care facilities and have a really a large proportion of older patients in your practice. Or you might be from a practice that's in a regional area, probably not from this PHN. You might have a certain specialty, women's health, mental health, etc. And you might be a solo GP, you might work in a big practice with lots of GPs. All to say that your patient cohort, your practice is different. So the way you interpret your report will be completely up to you. So none of this information is to say something is good or bad, but it's how you interpret it within the context of your practice that is the most important thing. So we've already talked about the socioeconomic demographics. Another important one is the age and sex profile. So how old are your patients compared to other practices in your region can really help you interpret the report, especially when it comes to things like hospitalizations for certain chronic diseases. Okay, so we're not going to go through the whole report. There's too much information in there. I'm just going to cherry pick a few key examples that might be helpful. So one of the first things you'll see on page 8 is a breakdown of the proportion of your patients who, within the same reporting period, 2020, have had an ED presentation, they've been hospitalized, they've had an outpatient service, been in an ambulance, had a mental health ambulatory care session, or died. And so to help you interpret this chart, on the very left, you can see that 5.9% of the patients in this made up practice, this is not real data, so don't worry about that, had an ED presentation compared to 18% with the PHN and 21% for the state, and so on for the rest of this chart. And just on this, it might seem quite simplistic, but this is brand new information for general practices that you just wouldn't be able to get any other way. So it's really interesting to see this for the first time for your patients. We take that concept to the next level in the chart on the next page, which is a Venn diagram, which talks about the combination of services that your patients have visited. So what this breaks down is helps you understand where patients have had multiple services. So the way you would interpret this chart is with the intersection of this red circle, so patients who are admitted to hospital, and the gray circle, which is patients who are admitted to ED, in between where they overlapped, there were 10 patients that both were admitted to hospital and presented to ED. And so in the report, it gives you some examples on the left-hand side of how to interpret that. It highlights the little section of the Venn diagram and then tells you what it represents and gives you some numbers around that. And this can be quite interesting as well. So one of the things that definitely GPs wanted to know early on wasn't just what proportion of my patients went to hospital, but also how frequently do they see me? So is it my frequent flyers that are going to hospital? That's what they wanted to know. So we put this chart together, which shows what proportion of your patients visited your practice based on the number of times they saw you in 2020. So the way you would interpret this is 70% of your patients had 1 to 5 encounters in that time frame, and 30% had 6 or more encounters. And this is a quite boring example because it's a random sample, but when you see your own report, it'll be a lot more interesting. So then we can take that same concept and apply it to different settings. So this takes it to 2 different levels, which is applying that to the proportion of patients that went to the emergency department, but also breaks it down by age group. So you can really start to get a sense of what's happening with your patients. So again, I might just pause here and see if there's any questions that have been asked in the chat. Not just yet. Okay, so I'll keep going. Another chart or another piece of information that's in the report has been repeated a couple of times, once for emergency department presentations and once for hospitalizations. So this report actually shows up twice. And what it's showing is for the most recent ED presentation that your patients had in 2020, what proportion of those patients visited your practice within a certain time frame before or after that ED presentation or hospitalization, whichever one you're looking at. So how you would interpret this? In the top yellow bar, you've got two different sides of the chart. This yellow house in the middle represents the ED presentation. There's probably a better graphic to do that, but that's what it is. And what it shows is on the left-hand side, this is before, and on the right-hand side, that's after. So on the left-hand side, it shows 16.3% of patients went to your practice 0 to 2 days before their most recent ED presentation. And 8.7% went to your practice 3 to 7 days before their most recent ED presentation. And you can compare that to the region and the state. Same thing for afterwards. What proportion went within a certain time frame after the most recent ED presentation? Well, why is that useful or interesting? One of our insights that we've put out and it's available in previous reports, is that typically if we know if patients see their GP within a week of discharge, the likelihood of unplanned hospitalizations over the next few weeks is significantly reduced. So there's certainly a lot of value to patients in continuity of care. And so how you might apply or interpret this information with your own practice and your own report is comparing those numbers. So in this example below, we'll just go through it. In the 0 to 2 days after the most recent discharge from hospital, 8% of patients visited your practice. In the 3 to 7 days after, that number was about 7%. But when you compare that to the region of 14%, almost 15%, and the state of 15%, that's significantly less. And then when you look at the next time period, 8 to 14 days, that number jumps up to about almost 20%, whereas for the region, it's a bit lower, 13 or 12% for the state. So basically what that means is for this particular made up practice, patients aren't getting to the GP within the first week, they're getting there in the second week. So that might have implications for continuity of care when you compare it to the region. So what could that mean? Maybe it's a rural practice or a regional practice and there's challenges around accessibility, travel, all of that kind of thing. Maybe it's a very busy practice and it's hard to get people an appointment without a waiting period. So what can you do? Maybe you can check that the hospital or the emergency department has your up-to-date contact details in the hope that they might be able to facilitate a discharge more effectively. Maybe they can help facilitate a follow-up appointment with your practice. Maybe there's an opportunity to use telehealth consults to see a patient sooner if they can't physically get to the practice faster. There's a lot you can do. And again, this isn't like a prescriptive guide of telling you what you should do. It's helping you, it's giving you examples that we've received from other practices and PHNs as to how you might use this information and how it's been helpful to other people. So I think that's important to note. I can just see there's a question here. From Alex, in the reports for the April 20, so comparing between the most recent reports and the previous ones from April, is there any generic trend in hospital and ED admissions? That's a great question. In these practice reports, we haven't compared different time periods. So I wouldn't be able to answer your question from the basis of the practice reports. Okay, so going on to another key page in the reports, it's around hospitalizations, and in particular, the certain key chronic diseases that are diseases of interest, and whether someone from your practice, one of your patients, was hospitalized in that 2020 period for one of those chronic diseases as their main diagnosis. So what was the primary reason they were hospitalized, or was it a secondary diagnosis? So not the reason for admission, but related to the hospitalization in one way or another. So how you would interpret this, you've got a little yellow dot representing the patients of your practice, and it's showing the proportion that were admitted to hospital with one of these chronic diseases as the primary diagnosis. So you can see this one has approximately just under 8.5% of patients who are hospitalized with cardiovascular disease as the primary diagnosis, compared to the state, which was a little bit less, and then the PHN, which was a little bit less than that, probably closer to about 6.5 or 7%. So how you might use this information is by really seeing if there's a particular need in terms of cohorts of patients in your practice. Is there, for example, in this example with cardiovascular disease, maybe there's an opportunity to implement CVD screening. Maybe there's not. Maybe it's a result of your practice demographic having an older population, and by that very nature, you're going to have more patients going to hospital for certain chronic diseases. This is a good example of why interpreting your report based on the context of your patient profile is really important, because it helps you make sense of this information. Some of the ways that we've heard from other practices using this information is one in particular I know of recognized that they were undercoding patients with chronic kidney disease. So they were able to go to their PenCat software, do a search for patients that were indicated to have CKD that weren't coded, and they reviewed that subsequently. And that was prompted by this report. So I mean, that's just one example of how you might use this information. And again, frankly, it's just interesting at the very least. So we then explore emergency department presentations. This is an interesting one because it talks about when your patients visit the emergency department, what time of day, and what was the triage category. So when you go to the emergency department, if your presentation is urgent, you're given a triage category of 1 to 3, which is resuscitation, emergency, or urgent. If it's not as urgent, you'll be a triage category 4 or 5, which is semi-urgent or non-urgent. And sometimes, not all the time, I really have to underscore, sometimes a triage category 4 or 5 ED presentation could be something that might have been a GP style presentation. So when you're interpreting this chart, typically what you'll find is one of two things. You'll find a spike in the morning just before business hours of triage category 4 or 5 presentations to the ED of your patients, or you'll see that at the end of the day around close of business. Why that might be happening, typically it's because Potentially patients are going straight to the ED. They don't know, they might not know that they can go to your practice at that particular time, or there was no capacity. There could be all sorts of reasons. It might be cultural. Maybe people are going to the ED because they don't know they can go to the GP. So what this chart might help you do when you interpret it is understand whether there's a need for the provisioning of after-hours services. If there seems to be a demand, there might be an opportunity to extend your opening hours, maybe a little bit earlier, maybe a little bit later. How you might make that decision is based on interpreting this chart correctly. So on the left-hand side, you can see the number of ED presentations as a number. And what you would need to figure out is that number high enough to warrant doing anything in terms of my opening hours? Maybe it's not, maybe it is. So again, it's very interesting, and how you interpret it is very important. But there's a lot you can do with it. We've also provided this same information for the day of the week. So you can see if there are any particular days. So probably if you're closed for 1 or 2 days of the week, chances are you might see a spike of ED activity on those days. And that brings us towards the end and to the condition in focus. So this time we're looking at COPD. So it's patients who have been diagnosed in your practice as having COPD, and gives you some information about their activity in the system and some other information. So for example, their smoking status, which is quite important, obviously, related to COPD. Their age, so we're just looking at patients above 25 or 25 and above. How many times they visit your practice within the year, and certain other related information like spirometry, whether it was measured or billed, whether that person has a chronic disease management plan or any respiratory medication. We don't know if the chronic disease plan was related to COPD or not. It's just whether they have one at all, and certain classes of medications as well are listed here. And so it's the proportion of patients with COPD that have been flagged as having that medication in your practice. Similarly, there's information around hospitalization, whether it was any hospitalization or specifically if it was COPD related. And then again, for any planned or unplanned hospitalization, ED presentations, and outpatient services, and particularly pulmonary rehabilitation. So really fascinating insights around your COPD patients. And to help make the most of that, we've developed an interactive tool, which I know Alex and the team at your PHN will be giving you more information about soon. But what this tool will help you do is interpret that COPD section of the report. It takes you through a guided questionnaire that gives you some practical and evidence-based resources and helps you really understand and assess your COPD patients and services. So again, more information will be coming out about that, but I highly recommend you, if you have that report, to express your interest in that, because I think you'll get a lot of value out of it. So that really brings us to the end of the presentation for tonight. I can see a question in the chat from Karen. Could the spike be due to GP referrals after examining the patient? Yeah, absolutely. They certainly could. So I guess to dive deeper into that insight of ED presentations, it's good to understand what's the source of referral. Quite common, I mean, the most common source of referral to the emergency department is self-referral or from family and friends. Actually, not a very high proportion of ED referrals are from GP, maybe approximately 10%, give or take. But most of the time it's a self-referral. But yes, that's a very valid point. And good question. Are there any other questions or comments from the audience? I'd love to hear.
Thank you, Adrian. I've got one more question, and it's what enhancements and what other data sets are you planning to include in the next year?
Great question. For the practice reports, one of the things that we want to focus on is making them available in a timely manner, so really speeding up the process of getting them back to practices so the information is as fresh as possible. What that means is that we probably won't be making too many changes, if any, to the practice reports in the near future, because that'll help us get them out faster. Sometimes when we add information to the reports, it delays producing them because they need to be quality assured and it's a bit of a process. So the reports probably won't change too much. One thing we are looking at is the feasibility of being able to look at the MBS and PBS in Lumos. So that might be coming in the next year or so, but that's early days. So at this stage, probably not too many changes to the practice report. And I see another comment coming through from Karen, which is, as you say, this is great information, risk evaluating patients and moving to structured chronic disease management, reduce ED admission.
Well, thank you, Adrian. That was a great presentation. Thank you. So I would just like to conclude by again thanking Adrian and thanking you all for attending. I know it's very late in the year. In fact, you're attending the last CPD for 2021. As Adrian said, we will be reaching out to practices registered in Lumos, which have received the Lumos reports in October, to participate in the COPD tool trial shortly. But the trial will only commence in February 2022. Please fill out your evaluations online after the webinar concludes. Thank you for your support throughout the year. Stay safe, and we hope you've got a great holiday season and see you next year. Bye.
Thanks, Alex. Thanks, everyone.
Thank you, Adrian.